Hello everyone. Today I'm going to talk about periodicular diseases. Before explaining this topic, I want to make sure that you guys have watched my previous video where I have covered about pulpal diseases. So in today's lecture, I'm going to cover periodicular diseases. Then in tomorrow's lecture, I'm going to cover endodontic diagnosis and rest of the topics. So let's begin. What is periodicular disease? So periradicular lesions of pulpal origin are inflammatory responses to variants from the root canal system. Patient symptoms may range from asymptomatic response to a variety of symptoms. So periradicular diseases can be in the form of a periradicular cyst or a periradicular abscess. It can be symptomatic or it can be asymptomatic. But if they are symptomatic, what are the different symptoms? You might feel slight sensitivity to chewing. There might be feeling of tooth elongation. Intense pain will be there. There'll be swelling. There'll be fever because of swelling and because of the infection. And you'll also see malaise. The sign most indicative of periradicular inflammatory lesion is radiographic bone resorption. You can notice that there is radiographic bone resorption, but this is unpredictable. Periradicular lesions are frequently not visible on radiographs. Now, classification of periapical diseases. So it can be classified as acute apical periodontitis and next. So acute apical periodontitis means you see the symptoms in a very short period of time. So I know that you all know about this, but I'm just explaining again. Acute means the symptoms arise all of a sudden. Like today, the patient might experience really terrible pain for next 3 days. Chronic means the patient might experience the pain over a long period of time. The same dull throbbing pain. So it doesn't mean that his pulp does not have an infection whereas his pulp has. It just means that this is asymptomatic, whereas acute infection is symptomatic. Okay. Next we come to apical abscess. Apical abscess, you see acute apical abscess, chronic apical abscess and phrenic abscess. I'll be explaining about each in detail. So the pulp in acute apical periodontitis and chronic apical periodontitis both are infected, and if left untreated they can form abscess. There might be pus accumulation over there and you can see something called as abscess. Now these are some few important points. Root canal sealers do not exhibit antimicrobial properties, and resin root canal sealers do not demonstrate antimicrobial properties. Now, I've also explained this in the previous video, but so when you check pulp vitality, there are different kinds of tests you do. You do cold tests where you apply endo eyes and see the patient. For the pulp vitality, you do thermal tests. You also do electronic pulp testing. Electronic pulp testing, all of this, when you test, the main thing that you get out of these testing is you know whether there is vascularity in the pulp or not. This is the only thing that you can get out of testing the pulp. Okay, and electronic pulp testing devices are contraindicated in the patients who have pacemaker, and these are not reliable in primary teeth and also not reliable in irreversible pulpitis. Okay, so we know that there are two fibers, A fibers. So let me just go through the explanation that I have explained in the previous video. So here I have explained you clearly that there are two kinds of fibers in the pulp, A fibers and C fibers. A fibers are myelinated, C fibers are short and unmyelinated. Now you can see that A delta fibers are larger myelinated nerves that enter the root canal and divide into smaller branches, coursing coronally through the pulp. Now, The sharp acute pain that you see, that you experience, is mainly due to A delta fiber pain. And as soon as you remove the stimulus, that can be, when you eat an ice cream, or you bite on any object and you feel an acute pain. And then as soon as you remove the stimulus, you can see that the pain subsides. That happens because of A delta fibers. Okay. Now, the association of these A delta fibers with that of the odontoblastic cell layer and dentin is referred to as pulpodentinal complex. Now coming to C fibers. C fibers are like the chronic pain, where you see a dull, throbbing, aching pain over a long period of time. So these are asymptomatic in chronic, like for example, I'm talking about chronic pain, where the pain symptoms are different from that of the acute pain, but it doesn't mean that the pulp is not infected. Okay, so the pain that is dull and throbbing is from C nerve fibers. The pain that is acute and really strong pain is because of A delta fibers. That is the topic that I'm trying to explain you. C fibers are small unmyelinated nerves. So A fibers are myelinated, whereas C fibers are unmyelinated. Okay. Now, unlike A delta fibers, C fibers are not directly involved with the pulpodentinal complex and are not easily provoked. C fiber pain occurs with tissue injury and is mediated by inflammatory mediators, vascular changes in the blood volume and blood flow, and it increases the tissue pressure. Now, so here, in case of irreversible pulpitis, and as well as in the primary teeth, they are saying that electronic pulp testing is not a reliable method. Now let us see why in primary teeth electronic pulp testing is not reliable. Because if there is any infection and the pain that you test and the pain that you observe, that is like acute pain, occurs because of A delta fibers, and these A delta fibers appear when pulp matures. So in a primary tooth, the pulp is not mature, and therefore you cannot see these fibers. It doesn't mean that there's no infection. So there is no reliability in this test. It only says whether this pulp is present and it's vascular or not. Okay. Another point, apical foramen of root canal. So here you can see this is the apical foramen of the root canal. It does not always lie along the long axis of the tooth, but it is 0.5 to 1 mm short of root apex. So it is 0.5 to 1 mm short of root apex. Apical constriction is the narrowest portion of the canal, located a few millimeters from anatomical apex. So here you see this apical constriction. This is the apical constriction and this is the apical foramen. Okay. Apical constriction, it appears few millimeter above the anatomical apex. Okay. Now, we'll see about external root resorption and internal root resorption in the later classes, but then this is just a question that has been asked in the board, so I have included this. So the more favorable prognosis is there for external root resorption or internal root resorption was the question. So more favorable prognosis is present in internal root resorption or external root resorption. The more favorable prognosis is present in internal root resorption. Next question is pulp in older patients. So In older patients, the vascularity of pulp decreases. Is it a true statement or a false statement? It was the question. So, in older patients, the vascularity of the pulp decreases, and it's a true statement because fibroblasts continue to produce fibrous tissue. The size of the pulp decreases with age due to continuous formation of secondary dentin. Decrease in pulp size decreases the vascular supply, nerve fibers, and overall cellularity and vascularity of the pulp. Now coming to acute abscess. So, yeah, before I teach acute abscess, let me go through endodontic diagnostic tests. Now coming to endodontic diagnostic tests. So there is cold test, thermal test, and also electronic pulp testing devices. So in the cold test, what do? You use endo ice, which is dichloro-difluoromethane, which is at minus 30 degrees centigrade. So the chilled pellet here you can see, it is applied immediately to the middle third of facial surface of the crown. So it is applied at the middle third of the facial surface of the crown for 5 seconds. Intensity and duration of response provide information about pulpal diagnosis. So, like as soon as you placed, if the patient feels something, it tells about their pulpal health. So the intensity and the duration of the response of the ice, endo ice, and the response that is being given by the patient, that will determine the pulpal diagnosis. Electric pulp testing machine. How do you use this? The tooth, suppose I'm testing in this tooth. It is isolated, it is dried. The electrode of the pulp tester should be coated with a viscous conductor, that is a toothpaste. The electrode should then be applied to the dry enamel on the middle third of the facial surface of the crown. Okay, the current flow should be adjusted to increase slowly. So you should increase the flow of the current very slowly. Okay. Next, the electrode should not be applied to any restorations. Thicker enamel will lead to a more delayed response. Thinner enamel of anterior teeth will yield a quicker response than a thicker enamel. Now, if the patient's medical history reveals that the cardiac pacemaker has been implanted, the use of electric pulpal tester is contraindicated. Okay, so the points to remember is EPT is not reliable in primary tooth. Why? Because primary tooth pulp matures later. So the pulp testing works only when the A delta fibers are responding, and this appears very late in primary tooth. So therefore EPT is not reliable, and it is contraindicated in case of cardiac patients where they're having a pacemaker. Okay, so vascular vitality of the pulp is more reliable method as compared to electric pulp testing method. Now coming to apical periodontitis. So there can be a symptomatic apical periodontitis and asymptomatic apical periodontitis. Symptomatic apical periodontitis means there is painful inflammation. So you can see the symptoms. Whereas asymptomatic means you do not find the symptoms, but in both the cases, the pulp is infected. So here you can see how a healthy gum and tooth is present, and here you can see gingivitis, inflammation you can see, and then it has progressed, it will lead to periodontitis, and it is an advanced situation where you see there is bone loss and deep pockets are present. Okay, now coming to symptomatic apical periodontitis, painful inflammation around the apex. So here you'll see a lot of painful inflammation characterized by painful percussion and intense throbbing pain. So whenever how do you diagnose it? When you do percussion, you notice that it's very painful for the patient. Localized inflammatory infiltrate within the PDL. Whereas in asymptomatic apical periodontitis, the pulp is completely necrosed. So you can see pulp necrosis. There will be an apical radiolucency in the radiograph and it is completely asymptomatic. Okay. Now, acute apical abscess. So there will be rapid swelling and exudate. So it occurs over a, like for example, here you can see this is apical periodontitis condition that is leading to acute apical abscess. So apical periodontitis, when left untreated, can cause abscess. Okay, and you can see the exudate. Now, chronic apical abscess, there will be draining sinus tract. Like for example, okay, so this is a patient's chin. Okay, now there might be an inflammation here, and on his outer layer of the chin you can see that there is something like this scar. Okay, this is nothing but draining sinus tract. The patient might get confused, like it appears like a cut with pus oozing out of it, and there is a case where patient has thought that it is a dermatological problem, but then it is actually the problem that has to be treated by the dentist because it is nothing but a draining sinus tract. There would not be any swelling, no discomfort. So how do you know exactly which tooth is the one that is the source for this infection? Okay, I will show you a picture in the next class. For example, suppose in this case I told you like this, in another case, so for example in the maxillary tooth, okay, you can see that you can see something like there is some tract over here. Only when you take a radiograph and you insert a gutta-percha cone and you stop it when you feel there is resistance, and then when you take a periapical radiograph is when you will know, and sometimes you'll be surprised to see that the teeth that you have thought has the infection might not have it and the adjacent tooth might have it. So the gutta-percha cone is inserted and you stop when there is resistance. You take a periapical radiograph and source and origin can be diagnosed. In this way you will know which is the tooth that has a problem. Okay, so this is about periapical diagnosis. Normal apical tissues means all tissues are sound and healthy. Then we have seen symptomatic apical periodontitis, which can it is having some symptoms. Asymptomatic means the infection is still present in the pulp and the pulp is completely necrosed. You'll see apical radiolucency in the radiograph. Now, acute apical abscess means there will be pus, exudate can be seen. Chronic apical abscess, you cannot see swelling, but you can see a draining sinus tract. Okay, now here you can see acute abscess. This is how it looks, the swelling that is caused because of abscess inside the tooth. If you see, like here you can see how it looks. Here if you see properly, the abscess is over here. Okay, so what is happening exactly? There is infection inside the teeth and there is an exudate around the apex. The lesions can also result from the infection and rapid tissue destruction arising from within chronic periradicular periodontitis, often referred to as phoenix abscess. So, like I told you, chronic periradicular periodontitis. This condition is something where you do not see acute pain. it is already, the pulp is necrosed, it is not yet treated. So you might assume like, okay, the patient might assume that, okay, there is not much problem. Just because there's no symptoms doesn't mean the pulp is healthy. It already, the pulp is necrosed. Because of this necrosis, an infection can arise and it will cause rapid tissue destruction and can lead to something called as phoenix abscess. Okay. The symptoms of phoenix abscess and acute apical abscess are identical. However, when a periapical radiolucency is evident, it is called as phoenix abscess. But whenever you see a periapical radiolucency, then it is called as phoenix abscess. Okay, so that's all for today's class. Next class, first we'll cover about endodiagnosis, treatment planning, and we'll also be covering cracked tooth syndrome, vertical root fracture, endo-perio relationships, and then we'll go ahead with surgical endodontics. So that's all for today. Thanks for watching and stay tuned to my channel if you have found it interesting, and if you have any questions, please do let me know in the comments below. And I hope you have enjoyed watching today's class. Thank you.